Hi, my name is Andy Charles. I'm a professor of neurology at UCLA and director of the UCLA Goldberg Migraine Program. I'm also the president of the American Headache Society. And I'd like to welcome you to this first contact webinar. And the title of the webinar is Headache Disorders and Sleep. So we're going to talk about the bidirectional relationship between sleep and different types of headache disorders. Here are my disclosures. I'm a consultant for a number of companies, and as I mentioned, I am the president of the American Headache Society. So here are the learning objectives for today. We'd like to have you recognize the specific relationships and different specific types of headache disorders. We'd like to have you appreciate how different therapies may influence both sleep and headache and implement strategies to manage sleep issues in patients with headache disorders. So as I mentioned, there's really a bidirectional relationship and actually multiple relationships between different types of headache disorders and sleep. And what we'll be talking about today is specifically migraine, cluster headache, hypnic headache, and headache associated with sleep apnea. Let's start with some diagnostic tips with regard to headache and sleep. So to begin with, multiple different types of headache can awaken patients from sleep. Migraine, cluster headache, and hypnic headache are among those that may awaken people from sleep. Whereas if someone has tension type headache, that typically does not awaken someone from sleep. So if you ask a question, does the headache awaken you from sleep? That's something that should, and their answer is yes, that's something that should point you in the direction of one of these three types of primary headache disorders. If the headache occurs consistently immediately before or immediately after sleep onset, that's something that really is highly suggestive of cluster headache, as we'll talk about. If the attacks occur later during sleep and are not associated with severe headache, this is something that should make you think about hypnic headache. Although this can certainly also occur with migraine, as we'll talk about, hypnic headache is characterized by onset later during sleep and more moderate headache. Sleep apnea, on the other hand, may cause headache that typically occurs upon awakening and may improve as the day proceeds. So these are just some general diagnostic tips to start with when you're taking a history about the relationship between different types of headache attacks and sleep. So let's talk about migraine and sleep. Migraine is commonly associated with fatigue and with the urge to sleep. So during a migraine attack, patients typically tell us that they really feel like they want to lie down and go to sleep. On the other side, irregular, and that means either too much or too little sleep, may trigger migraine attacks. Migraine can commonly disrupt normal sleep patterns, and this can create a vicious cycle in which sleep disturbance caused by migraine further exacerbates the problem. And so this is why it's important to intervene with sleep issues when possible to try and break into this vicious cycle. In chronic migraine, interestingly, light avoidance may reduce the normal day-night light exposure patterns that help to set the sleep-wake cycle. So chronic migraine patients frequently will be wearing sunglasses at all times throughout the day. And it turns out that UV light on the retina is one of the primary things that sets the sleep-wake cycle. And so this is a problem potentially for some migraine patients if they're avoiding light to the extent that it's interfering with the normal light-dark cues that set the sleep-wake cycle. This is a slide that basically demonstrates different aspects of sleep: sleep need, sleep ability, and sleep opportunity. And I just put this up because I think it's important to think about how migraine affects all of these. It certainly causes a sleep need in some patients, It may interfere with the ability to sleep because the sensory sensitivity associated with migraine makes it tough to go to sleep and stay asleep, as well as the pain. And the sleep opportunity may be something that is also affected by migraine, so that, for example, if a migraine attack occurs during the day, there may not be the opportunity to be able to sleep when there's a tremendous urge to sleep as a consequence of a migraine attack. Another important issue that's related to sleep is caffeine. So just talking a little bit about the chemistry of caffeine, adenosine is a potent inhibitory neurotransmitter that's a product of energy metabolism. So breakdown of ATP, the energy source, produces adenosine. Now, accumulation of adenosine in the brain is believed to be a primary component of the metabolic drive to sleep. So as the day proceeds, adenosine is building up in one's brain, and that's something that is part of the drive to sleep at the end of the day. Caffeine is a non-selective antagonist of adenosine receptors, so it's essentially blocking the effects of adenosine. And so this is something that is important in terms of its awakening mechanisms, but may also be important in terms of the issues with caffeine and migraine. I think most of us know that caffeine is a double-edged sword for migraine patients. So it's very well known that ingestion of caffeinated beverages is a common approach to the acute treatment of migraine. So a cup of coffee or a cup of tea is something that migraine patients may go to, or a cola as an approach to treating a migraine attack when it occurs. Caffeine is included in multiple different combination analgesics, along with acetaminophen, aspirin, or other nonsteroidal anti-inflammatories that are used as acute therapies for migraine. So commonly used example of this is Excedrin migraine, which includes both caffeine and NSAIDs and acetaminophen. On the other hand, it's now been demonstrated in controlled studies that withdrawal from regular use of caffeine can trigger a migraine attack. And in fact, caffeine withdrawal headache is one that's defined in the International Classification of Headache Disorders. So this is what we mean when we talk about it being a double-edged sword. It can be helpful as an acute therapy, but when used regularly and stopped, it can trigger migraine. Well, how about insomnia and migraine? So insomnia is extraordinarily common in migraine patients. It may contribute to migraine and vice versa. And certain insomnia treatments may exacerbate migraine. Benzodiazepines or non-benzodiazepine sedatives like zolpidem, for example, anecdotally seem to worsen migraine in some patients. And again, with the caffeine issue, caffeine-containing analgesics taken for migraine may exacerbate insomnia, and patients may not realize how much of the caffeine-containing analgesics they're taking, especially if it's later in the day, may be worsening their sleep. So what are the therapeutic approaches for sleep issues associated with migraine? Well, a common, simple concept is to keep sleep timing and duration as regular as possible. There's not any set amount of sleep. This is going to vary from individual to individual, the extent to which they need a certain amount of hours of sleep. But if they can sort out what it is that is their ideal or optimal sleep duration and timing, then that's something that if they can keep it as consistent as possible from day to day, that will be helpful. Other approaches include good sleep hygiene. I don't have time to get into this. This is a whole topic in and of itself. But things like not exercising immediately before bed, avoiding stimulation before bed. And another important one is actually avoiding large meals immediately before bed, because this can be something that is both disruptive for sleep, but also maybe something that's particularly an issue for migraine patients. There's different approaches to caffeine. My own approach is that if someone enjoys caffeine or finds it useful for them, I don't necessarily tell them to discontinue it altogether. Some practitioners do suggest elimination of caffeine. My approach is to tell patients to take caffeine if they are going to, but importantly, keep it as consistent as possible from day to day, and then also limit it to the morning. So avoid afternoon or evening caffeine, which may be much more problematic in terms of sleep, but also in terms of migraine. There's some studies suggesting that melatonin may be helpful for migraine, particularly in children and adolescents, but also in adults. This is certainly something that can be tried as an approach to insomnia that is a non-pharmaceutical approach that may be helpful, again, both for sleep, but also potentially having a preventive effect for migraine. The other choices for migraine include migraine preventive therapies, particularly low-dose tricyclic antidepressants. Now, this is an off-label indication. There's not strong evidence to support this, but it's certainly the case that tricyclics have evidence to support their use as migraine preventive therapy. And in a number of cases, they can be helpful as medications that can solidify sleep and help people to fall asleep. The key here is finding a dose that does not cause drowsiness upon awakening. Another one that is very much off-label that we do use in our practice as a medication to treat insomnia in those with migraine is gabapentin. Again, very much off-label. There's no evidence to support this, but anecdotally, we have found this medication to be helpful, particularly at low doses for some individuals with migraine, and can avoid some of the issues that are created with some of the other sedative hypnotics. Generally speaking, we like to avoid benzodiazepines or non-benzodiazepine sedative hypnotics, such as zolpidem. So these are ones that where we would prefer for those with migraine and insomnia to use one of these or to institute these other approaches rather than using these particular medications. Okay, switching gears. So here's a clinical case. 40-year-old man with no previous history of headache. For the past month, he awakens every evening at 12 p.m. With excruciating headache. Each attack lasts approximately 2 hours. The headache is located primarily in and around the right eye and is associated with marked redness and tearing of the eye. During the attack, he gets out of bed, he paces in his bedroom, and sometimes he bangs his head with his hand. So this is a classic description of cluster headache. So here you find the ICHD-3, the International Classification of Headache Disorders, diagnostic criteria for cluster headache. I'm not going to go through these entirely, but basically it's a severe or very severe unilateral orbital or periorbital or temporal pain lasting 15 to 180 minutes if untreated. And the headache is associated by a variety of cranial autonomic features. Importantly, one of the most distinguishing features from migraine is this sense of restlessness or agitation. So migraine patients, when they have an attack, will lie still in a dark, quiet room. Cluster headache patients will pace, bang their heads, do a variety of things that migraine patients would never do during an attack. So this kind of circadian association between cluster or of cluster attacks, I should say, is a very common feature. And the occurrence at night is something that often gets people thinking about the relationship between cluster headache and sleep. Is there anything to do about sleep with cluster? Well, there isn't anything specific apart from those sorts of things that were suggested in terms of sleep hygiene and consistency of sleep. A couple of things that are interesting that may be helpful. One is high dose melatonin. And by high dose, I mean 5 or even 10 milligrams at bedtime. This is something that may be helpful for some cluster patients. This is something that is, practically speaking, very difficult. But anecdotally, just as a matter of interest, we found that if people during a cluster episode have a major change in time zones, let's say go to Europe, or I have one patient who travels to Australia, happens to have the means and the availability to do that, that is something that can break them out of the cluster episode. So I bring this up not necessarily as a recommended strategy, but just something to tell you how this interesting relationship between cluster headache and the day-night cycle is one of its defining features. Here's another clinical case. This is a 60-year-old woman with a history of migraine that predominantly resolved 2 years after menopause. For the past 2 months, she awakens almost every night at 3 or 4 in the morning with a moderate bilateral headache. There's no nausea, no light or sound sensitivity. There's no redness or tearing of the eyes or runny nose associated with the headache. Each attack lasts approximately 1 hour. And on most nights, she's able to return to sleep, but on some nights, she basically stays up and is up the rest of the night and into the day because she's unable to return to sleep. So what's this diagnosis? This is hypnic headache. So these are the ICHD diagnostic criteria for hypnic headache. Of importance are that they develop only during sleep and cause awakening. They generally occur on more than 10 days per month, and they are persistent. They last about 15 minutes for up to 4 hours. They don't, generally speaking, have cranial autonomic symptoms or restlessness, and they're not better accounted for by another ICHD3 diagnosis. And the main one that is a question, it would typically be migraine. So hypnic headache usually begins after 50 years, but can occur sometimes in younger people. The pain is usually mild to moderate, but occasionally severe pain is reported. It's usually bilateral, usually lasts between 15 and 180 minutes. Most cases are persistent, as I mentioned. It was thought in general that hypnic headache had tension type features, but recent studies have shown that some patients may present with migraine-like features. And it's been speculated that perhaps the onset of hypnic headache is related to REM sleep, but this has not been clearly demonstrated in multiple studies. Just quickly before I'm moving on to the talking about sleep apnea, the treatments for hypnic headache, the one in particular that is quite interesting is caffeine taken at bedtime. So this is something that can be very helpful for some patients with hypnic headache. Paradoxically, it doesn't seem to keep people awake. So low doses of caffeine at bedtime for hypnic headache are generally speaking, the first line therapy. Other treatments that can be tried include verapamil or indomethacin, but usually we like to start with a therapeutic trial of low-dose caffeine. Okay, moving on to sleep apnea. So headache upon awakening is reported fairly commonly in those with sleep disordered breathing. And this could be due to hypoxia or hypercapnia, which can occur as a consequence of sleep apnea of different kinds. What is the relationship between this and migraine? Well, snoring is a risk factor for chronic migraine. And we do believe that sleep apnea may not only cause morning headache that is problematic and perhaps distinct from migraine, but it's possible that it's also a risk factor for chronification of migraine as well. On the other hand, population studies did not indicate an increased prevalence of obstructive sleep apnea in those with migraine as compared with the general population. And it's also important to remember that migraine also commonly occurs upon awakening and is something that is always in the differential for a headache that's occurring either out of sleep or upon awakening. So a tough question is, when should you order a sleep study in someone with headache? There's some people who would say if there's snoring reported at all in a patient with significant headache, that's a reason to order a sleep study. But honestly, there's no solid evidence to support a decision about this. Sleep studies are expensive, and even if one does identify, for example, obstructive sleep apnea, that doesn't necessarily mean that you're automatically going to change management. And so this can sometimes be a tricky decision. From my perspective, I would consider a sleep study with an individual who has symptoms suggesting sleep apnea, not just headache, but other symptoms suggesting sleep apnea, and has headache upon awakening, or is having increasing migraine attack frequency in spite of appropriate therapy. So if you have someone with migraine who's not doing well with your therapies, has symptoms of sleep apnea, and the migraine seems to be progressing, that's somebody for whom we might order a sleep study. The other approach, particularly in people who have weight issues, is to address these right off the bat. So really work on weight as a primary factor to addressing both migraine and potentially sleep apnea as a primary step to take before actually pursuing diagnostic workup and therapy for sleep apnea. So I'll close there with this summary. Sleep is clearly an important factor for multiple types of headache disorders. It's always good to advise paying attention to sleep hygiene in patients with headache and focusing on consistency of sleep timing and duration for any type of headache disorder. Pay attention to caffeine, which may be a significant issue, and if one is going to allow caffeine, suggest that it be taken very consistently in small doses and limited to the morning hours. Medications for sleep can be a significant issue. There are a number of different medication approaches that can be taken for insomnia in patients with migraine, but generally speaking, we like to avoid medications that are specifically used only for insomnia in general. So with that, I'd like to close and thank you for your attention, and hope you found this information useful. And I hope you appreciate this, the First Contact program, which we believe is really a showpiece for the educational efforts of the American Headache Society. Thanks very much.